you know, harvesting bone marrow, how painful it is gonna be that anterior iliac crest.
Very.
So, and the reason why they get such high doses of chemo or total body radiation is just that to destroy the leukemic cells in the bone marrow. Give the bone marrow back to the central line. So when it's autologous, it just means using a patient's own bone marrow. So don't kill yourself. Autologous just means it's their own. Allogenic means truly it's the same species. But who's a better match for allogenic?
Family.
Yeah, right. Sibling, yeah, who else? Right. If you're related to them, better. And same thing. Autologous. If a relapse occurs, we're gonna get the lethal doses of chemo radiation again. So that's that remission phase of the chemotherapy.
I have a question.
Please, don't.
It might be gone.
It's not.
But, to be considered a match, is it just, like, same blood type, or?
Well, no, it's be matching just like if you're getting an organ, like it's tissue
Okay.
typing
Okay.
and checking for antigens, like it's really, yeah, it's a lot more than that. So it's not a dumb question, but it's really complex. That's why, yeah, and we said again, during that time where the bone marrow is totally destroyed, they're gonna be severely immunosuppressed. So the same as we said before. And in infection, so one more time, out of malnutrition, infection, and bleeding, infection's gonna be our biggest thing. And the next biggest gonna be
Bleeding.
bleeding, right, yep. And then stem cells, it's just, little pinch of stem cells, doesn't matter. Just with stem cells, they can, grow into can grow into anything. That's the beauty of them. So sustain replacement of patient's blood cell line is gonna be, you're not getting the big jam sheeting needle into your iliac crest. So patient comfort, donor comfort. The same thing is gonna be tissue typing for stem cells. So here's a big one, hematopoietic growth factor to the donor. So one more time, why don't I give hematopoietic factors to somebody who has leukemia? Beautiful, right. So hematopoietic is gonna be epigen, apopoietin, compared to neupogen. Oh, yeah, sorry. No, that's okay. So, remember, neupogen, white blood cells, you would give them, to stimulate, in certain cases, but really want to be careful. But the donor now is getting them to help build up the donor's getting epigen, apopoietin, to build up their red blood cells.
So people who have leukemia, they're just not given it because if they produce more white blood cells, they'll be immature.
Well, so if you give them erythropoietin, it's gonna stimulate, it could potentially, it's gonna stimulate all the blood cells to grow, white and red. And we don't want more abnormal white ones.
Okay, so whenever they're created, they're like they're abnormal. That's why.
Exactly. Mhm.
Is there a term for that? Like, no, I mean, other than that, they call it like, it almost like slows down like the blood. You know what I'm talking about? Because there's so much white blood cells in there. I don't even exactly how to phrase it. The question.
We'll think of it. It might be, I might be omitting it, come back to it. Not springing to head, mine. And again, so stem cells, it's gonna increase the stem cells in the peripheral circulation of the donor. And use the stem cells for transplants at the bone marrow, so again, more comfortable for the donor and patient, but risk factor given hematopoietic growth factors for the recipient is chance to stimulate leukemic cells. So peripheral blood removed, white blood cells separated from the plasma, and then you're gonna give those back. And this is why umbilical cord is even better. Umbilical cord blood is better for stem cells. A lot of stem cells in the umbilical cord blood. So, before a stem cell transplant, again, I wanna suppress the person's immune system as much as I can, and that's really, 'cause you don't want them to reject the transplanted material. So that's why they're getting that high dose chemo radiation to help, it's really to enhance the success of the transplant. So lethal dose of chemo, nearly, but obviously we're gonna, don't wanna kill the person. And for the stem cells, similar complications with bone marrow transplant. This is gonna be infection and nice little picture. So apheresis is just a machine that separates cells to do other great things, removes, separates, also used in like autoimmune disorders to help separate the antigen from whatever's causing the autoimmune disorder. Come up with an apheresis machine. So here's our big complication. With an allogenic bone marrow transplant, and that just means I'm getting it from a sibling, relative, so the risk for graft versus host disease. So it's just that the recipient is recognizing the cells as foreign, and that's true, and then the donated T lymphocytes attack liver, skin, and GI tract. So there's two types: acute that happens first 3 months, and some should say first 100 days, that's the same thing, and then it's after 3 months. How it can increase incidence to have graft versus host disease happen is if it's not matched properly, which hopefully that's not true. If the donors are unrelated, so if you're getting it from a bank, if you're older age, just the longer you live, you're gonna have more antigens and antibodies. And then CMV, so CMV cytomegalovirus, you'll have to write that down if you want, but cytomegalovirus, plenty of people have and you're asymptomatic, but it's, when you're immunosuppressed, it blossoms as an infection and starts to reject a lot. So anytime anything's getting transplanted, bone marrow, stem cells, solid organs, worry about CMV infection. They screen for it, but it's difficult to detect. I'm sure it's better now than it was years ago. So, and practice-wise, sometimes if it's mild graft versus host, they really won't do anything. Like the person can kind of, if their system's okay, they can overcome it without a lot of treatment. But obviously, if it's severe, then we're going to treat the symptoms of it. So skin-wise, would be your epidermis and perifollicular dermis, so you get bad rash and desquamation. So desquamation, just like we talked about with radiation therapy, is hyperpigmented skin or deep erythema, could be open and weeping. And it disrupts the small bile duct, it increased LFTs, jaundice. What else would you get? Yellow in the eyes, ecteric sclera. Definitely could get itchy. And then plus, you have your whole rash going on with the skin anyway. So increased pruritus. So we have whole icterus and pruritus. And then mucosal ulceration for diarrhea. So we think bad volume problem, volume deficit. And what else is going to happen? If I break something in my perianal area, and somebody's immunocompromised,
infection in the
yeah, that
peritoneum.
could lead to infection all through the system too. So, diarrhea, continuous fever, blisters to the skin, dermatitis, hepatitis. So bad pictures, all part of it, but this will probably real very sloughing off the skin. So to treat it, mildly, antibiotics and steroids. So antibiotics to help treat the infection, steroids like prednisone to suppress the immune system, and other immunosuppressant things. So thalidomide, famous or infamous for limb disturbances in children, so it's given it, in the sixties, had a lot of bad limb problems, so it's category X. Drug category X, so it's, known to cause birth defects. Cyclosporin, another immunosuppressant. And tacrolimus, immunosuppressant given for organ transplants. So important for tacrolimus to check the levels to make sure you're not getting toxic from it. And now for tacrolimus, because it's been linked to cancers like this, they kind of treat it like a chemotherapy drug too, with using special gloves and special garb to administer it. If we look for that one, anything, pregnancy warning, you want to avoid people, meaning nurses who are working with it of childbearing age. And really, men and women, all these not just going to be female nurses, but really both genders. So then you can also give interferons and interleukins because they're immunomodulators themselves. So really, to inhibit, the money line is that last little segment to inhibit cell growth, proliferation and cell growth of the leukemic cells. So that's what we're giving interferons. So the big adverse effect of interferons, unfortunately, is flu-like effect, flu-like symptoms. So fatigue, lethargy, weight loss, muscle aches, joint aches.
I have a question.
Please.
For the graft versus host disease, how was it even diagnosed?
By the person's presentation. So you're getting that rash, you're getting jaundice, so by the signs of it.
When did they traumatize the other thing? I don't know.
Well, I think after somebody's had a bone marrow transplant or a stem cell
Okay.
transplant, and now they have, bad skin problems and all that. But
Okay.
you would be more, so, listen, that could be a test question right now. I'm cooking it right in my head. You're gonna have graft, you worry about signs of graft versus host after they've had a stem cell or bone marrow transplant. Because it is similar to things you could just get from chemotherapy, but it's more likely to be that. And then, of course, you can use complementary therapies, knows the same benefit, but if it's gonna help the person's spiritual health and comfort and help reduce their stress, that's what we wanna go for. So now, let's hit it again. Just some highlights. Leukemia in general means, the leukemic cells are crowding out the bone, crowding out the good things in the bone marrow. Infection, bleeding, anemia, love it. All those skin changes. And think ALL is gonna be for children, AML is adults, and the APL has a better prognosis for adults. Our rods were with AML, and the Philadelphia chromosome is with CML. Not gonna be more of those little factoids, because now we're thinking about, okay, nursing-wise, what are we gonna do? Always thinking, kids, always thinking, we're always thinking.
Part of one of the slides. It's just mentioned that has better survival rates.
And here's the old nursing care. Great Roxborough nursing care. So just like it, usually starts on everyone. So health promotion wise, think that, unfortunately, there's not much we can do other than, try and decrease the radiation risk and exposure to chemicals. But this is important. This is why for children, like, you don't want to do undue radiation for, get X-rays unduly for children and make sure they're really using the lowest percentage of radiation they can if they need films, because you're worried about the cells mutating. So you think it's not so wild to talk about radiation. Of course, cigarette smoking, because remember, it was for ALL, if the parents are smoking, pre and post infant, higher risk for that. And then for Down syndrome, high risk for ALL because of the chromosomal problems. And people high risk for Down syndrome if you have a family history or you're older maternal age. So the focus is related to leukemia. So they're just coming in. Are they gonna have some like dramatic symptoms with leukemia? If I'm just starting to get diagnosed? No, it's gonna be vague things, achiness, general malaise. Oh, I'm sorry, I didn't give it to you.
I don't know.
I have too many. Yeah, maybe low-grade fever, just mild things. Sorry, Marissa. That's okay. And then physical examination, this is early, so think, when I'm first getting diagnosed, I might not have weight loss, but I'm just gonna, again, just be generally, maybe have a little bit of, just not feeling that well. But could be weird things. I could start to have bleeding abnormalities. I could have maybe frequent nosebleeds, say. Because again, you're thinking of the cells are, the leukemic cells are pushing out the good platelets. What else? Bruising, like frequent bruising. You notice bruises all over somebody and they, haven't fallen or haven't done anything. How it would present just early on. So nosebleeds, frequent bruising. Maybe they can't say petechiae, but these little red dots, I don't know where they're coming from.
Do they have like low-grade fever?
Yep,
What was that, I'm sorry?
low-grade fever, like I said, like the whole, just general odd flu-like things.
Would you call it like general malaise?
Yes.
You would call that?
And again, they could have some low-level signs of infection, like cough. But nothing dramatic. But when we look at the person, we are inspecting them and seeing like these weird bruises all over. But I'm gonna do my usual head to toe assessment. So diagnosis-wise, I don't know, infection and other times, imbalanced nutrition, risk for bleeding, there's not enough risk for bleeding, weird nursing lingo, and then breathing, inflammatory breathing. So vital signs, every 4 hours, more often if needed, and then, so what are you gonna report? What abnormal things? You're gonna, once they're in the throes of this diagnosis. We know they have leukemia now, so you're gonna be worried about
Temperature, for sure.
temperature above 100.5, beautiful. So tachycardia, hypotension, think they can have orthostatic hypotension. And lab values, so I'm concerned about their CBC, which includes the white count and their platelets, hemoglobin and hematocrit, and the bleeding time, so PT, PTT, and INR.
We probably got the MCD and.
Yeah, you could check those too, you could check the red blood cell indices, because we're
Did-
extra smart.
Did you say LFTs?
So,
No.
early on, maybe not early on, but once their blood sugar
Bless you.
is, but you would once they're in treatment, like once I'm getting chemotherapy, or once I'm trying to evaluate for the graft versus host. But early on, you wouldn't have liver abnormalities.
So early on, just CBC, PT, PTT, INR. Okay.
And then, of course, really, we're always gonna check their whole
Schlew.
chemistries, but particularly CBC for here. So risk for infection, so nursing, what we're gonna do? Nurse Richie said it already, so they could be a protective isolation, because I'm protecting the patient. Obviously, hand hygiene. So anybody having a cold, flu, any signs of infection, really shouldn't come see them. Oral hygiene, so remember, it's every meal, so don't get tripped up. Usually, every is a destruction will go for, but it's every in this case, just because of the high risk for infection. Sneezies in the back. And I think, just what we talked about, way back when we were talking about cardiac things, people taking prophylactic antibiotics because they have heart problems. Like any infection in your mouth is easily transmitted to be systemic, especially when you're immunocompromised. So that's why it's every meal. And salinine's good, dilute chlorhexidine, hydrogen peroxide. So then avoid invasive procedures. That means, obviously nothing IM, no IM injections, but nothing per rectum, nothing per vagina. So no suppositories, no enemas, no tampons even, because just worried about infection. So one more time, neutropenia, not gonna be calculated, but how you factor it is the bands plus the neutrophils, multiple by the total white blood count. If it's greater than 1,500, great, and then less than 500, severe risk. There are degrees of neutropenia. Don't want you to cloud your mind more numbers than you need. Just, 500 really terrible. But even with, 800, are they gonna be at risk if it's 800? Yeah, sure are. And then, so the nadir, remember, that's at the lowest point of your white blood cells, but think, it's also the other lowest point of the other components of your blood too, so the hemoglobin and hematocrit are gonna be really low then too. So you think 17 days after they're getting some chemotherapy is gonna be at its lowest point.
So back to the neutropenia, so if it's even below 1,000, or the average?
Yeah, I mean, it's mild neutropenia, but it's just those numbers in the middle vary by the institution and really what's wrong with the patient, so I just keep it a basic. 500 is definitely terrible. And great question though, because even when it's mild, are we gonna do all this stuff? Yeah, you're still gonna do it. So mild care again, then liquids, different textures, different tastes, rest periods, frequent meals with high calorie snacks. So what's that mean? Peanut butter, ice cream, like anything that's gonna help out with your calories. So I didn't want you to get messed up because some sources say, don't have them drink with things because it'll fill them up. But kind of logical thinking, if all they can do is taking calories by drinking them, then you're gonna wanna do that. Like however's gonna maximize their calories you wanna do. We already did this one. You're gonna medicate them before they get nauseated, so before they eat. Commercial supplements, like Ensure, no one will plug Ensure, they're not giving you money. And nothing unpleasant before meals. So what's that mean? The bone marrow aspiration like we talked about, even just, anything that's gonna cause them more discomfort. You don't wanna do that right before you're trying to eat something. I omitted the ones, things like, offensive smells, like, if you're barely able to eat, like, and something really makes you sick, like, opening a can of tuna fish is not the thing to do if, that's gonna be a trigger for the person when they're feeling well. Some other high smelling food. So why do we maintain the nutritional status? Obviously, it's all common sense. Help with their general health, decrease morbidity and mortality, help up with their weight, their response to treatment, minimize any adverse effects, and obviously, help you feel better, quality of life. That's a lame slide, don't look at that one. It's all common sense, that one. So now these impaired oral mucous membranes, so now they're inflamed and ulcerated, so we're always looking at mouth, gums, sublingual area, throat, for swelling and lesions. So asking about how they feel, the breakdown's gonna cause more infection and bleeding, like we already hit. And then if I have these terrible mouth sores, it's gonna affect my appetite and how much I can take in. And then it could be so bad if it's affecting my esophagus also, that's really gonna be an airway issue. That would be really severe. We're just trying to intervene before that can happen. So you can culture them. So like vesicles, so vesicle is fluid-filled blister, compared to Candida is yeast, and that can be white, black furry, bright red.
Should we know that?
Be good. But we've talked Candida before. When did we already talk about Candida?
Antibiotic.
Yes, yeah, So I'm not talking crazy. You heard that already. So you just have to really think about, now herpes is the vesicles. And if you've had a cold sore, hate to break it to you, herpes. So you might have had personal experience. And so what are you gonna do? Because herpes is a virus, what do you take for that? Yeah, antiviral medication. And what are you gonna take for the Candida, such as yeast? Antifungal. Got it. In addition to doing our great mouth care thing.
Which is gonna cause diarrhea and more.
Right. Unfortunately. So you don't have to remember this concentration, we already hit it. Saline, hydrogen peroxide, but add in chlorhexidine, because that typically is, more contemporary thing. Not that you'll see it, but it's true. And then doesn't have to be petroleum jelly, could be whatever lip product you wanna use. Burt's Bees is fine, whatever you wanna do. The old soft bristle toothbrush, or tooth that with the sponge. And then crap. So antifungal, we already got the nice status of antifungal, we talked about that one back in the antibiotics. So I just want you to be cautioned with the lidocaine though. Really, lidocaine, you might see it still crazy ATI wise, but typically we don't want to promote lidocaine in people who have a lot of mouth sores, because you can have systemic absorption of lidocaine. And if you have a lot of systemic absorption, it's going to cause central nervous system problems, cardiac problems. So irritating that it's still out there, like, but you don't use that as much as you used to. And plus it generally is in like an alcohol base, so it can burn itself. So just real life wise, don't go for that. But you might see a standardized test wise. I'm not gonna have it all in there.
Was that normally used for like the herpes simplex lesions?
No, more it's just like, it used to be when there was open area, like it was a thing, magic mouthwash. It was Maalox, Viscus, lidocaine, and Benadryl. It was a very pretty pink color. But people would, because it did help, like, temporarily. It's just like putting Ambisol into you. It helps a little bit, but really, long term, it's causing the person bad effects. And like I said, it's the CNS disturbance and, really potentially to dysrhythmias. It's only there, ATI and Clexline. Better is gonna be doing what? The rinses, just saline or half-strength hydroperoxide. So pursuant to that, since they might be ulcerated, nothing alcohol-based, no alcohol obviously, but citrus fruit juices, spicy things that, you know, vary in temperature, crusty foods. So just cool, not cold. We wanna make sure they're having adequate hydration. So now, thrombocytopenia, so same thing, we're checking their vital signs, and checking body systems for bleeding, so really, you know, again, just doing a whole overall inspection. You know, common to have epistaxis, you know, nosebleed, common to have, you know, oozing, because I'm worried about them going into DIC. And if they're starting to ooze all over, then that's gonna be concerning that they're going into DIC. So I'm checking their skin for what are three big things. We already talked about the skin problems. Little red dots are the petechiae. The larger purple blotches are, well, purpura, but they're ecchymosis too. They're purpura with a purple, ecchymosis is they're yellow and greenish, whatever color. And what else? What is it? Purpura, petechiae, ecchymosis. Again, checking gums, checking for epistaxis, conjunctival for bleeding, so you know you have the bright red conjunctival hemorrhage. So your sclera now, they aren't red, they aren't yellow, they're not white like they should be, they're bright red. So checking anything they excrete for blood, so you know, send it to the lab, because you know, we're not gonna see it if it's occult bleeding. So we have to check hemoccult or gastrocult for vomitus. And then prolonged bleeding at puncture sites. So it could be that they, you know, no, real life is unlikely you're still gonna have any peripheral sites. But just, you know, if they do, checking those sites. And if they do need a puncture, you're really holding pressure for a good 5 to 10 minutes to make sure just achieve hemostasis. So here's a biggie. So neurologic symptoms, headache, restlessness, altered mentation, visual changes. That's because they could have intracranial bleeding now. Our big thing is going to be anything with your central nervous system. Early sign is change in mental status. But there's other things that are early too. I'm not waiting until they have a seizure. And yeah, but you smelled it, birthday girl. Bleeding is going to cause that increased intracranial pressure too, because remember, it's our three components, tissue, blood, and CSF. Now I'm having too much blood, because I could just start, unfortunately, having spontaneous intracranial bleeding. Also checking the abdomen, so any abdominal pain, if they're having guarding, so they're tensing up when you go to examine them, or increasing girth. And why is that? Because now they could be having, well, not a size, if it's blood, then it's gonna be, hemorrhaging and more free fluid to your abdomen. And free fluid to your abdomen is something you already know too. Yeah, peritoneal signs. So not, it's gonna be peritoneal signs, which are, well, pain, What's our
Abdominal
big
distension.
physical maneuver for peritoneal signs? Rebound tenderness?
Yes.
So you push it, not when you push it, but when you take away your hand, so rebound tenderness. Are they gonna be moving around and coming out of the room yelling for ice or whatever? You're late with a tissue box? No, if I have peritoneal signs, I'm curled up in a ball because I have so much pain. I'm not moving around. I'm talking because it hurts. I'm taking shallow breaths because I can't move. It's so much pain. So free fluid, in this case, is going to be blood. And what other objective findings? Vital signs wise, you're going to have
Tachycardia,
beautiful. They're going to have what else?
hypotension,
Hypotension.
Maybe,
Yeah, you know, right, if it gets really bad, it's gonna affect my breathing, but early on.
maybe
they can-
temperature. Temp?
Maybe not temp, just for this free fluid. I mean, if it's sitting there, we don't want it sitting there. We said the GERD, cervical tenderness, tachycardia, hypotension. I don't know. That diffuse pain, I think it's gonna be diffuse pain for free fluid in the abdomen. Again, for thrombocytopenia, and what you talked about, clinically, really, it would be if the kid was below, oh my God, 50,000. I know, a normal being 150 to 450,000, so 50,000 is extremely low. These are climbing up on it. One more time, nothing per the rectum or vagina. Why? Because we don't want to create any bleeding, so very thin mucous membranes to both areas. And the twofold is a little bullets there for, because we also are not doing that because of problems with infection. So, because of bleeding and infection. I said no eye injections, obviously, because I can't compress if it starts bleeding. There's definitely nothing, again, that's gonna, no diagnostic procedures, nothing involving a large needle. Okay. Pressure to the site, 3 to 5 minutes. I know this is a gross one, but
Pick your nose. Nice.
no nose blowing, no nose picking, straining at stool. So one more time, you're really, you know, when they go to the bathroom, you're really checking to make sure what color the stool is. Okay? I'll start having black tarry stool, I know that's a problem too. Because think that bleeding can start anywhere along the GI tract. It could be into my peritoneum, but it could be along my GI tract too. And I missed the, see, easy, so silly of me too. What would be one just staring us right in the face before we even get to the vital signs? When we look at that person, what are they gonna look like? Yeah, pale, so where we checking for pallor?
Nail
It's a
bed.
dark chocolate, Idris Elba, my man, develops leukemia. Where am I gonna look on Idris? Everywhere.
Nail bed.
They're kind of unified.
Yeah, sclera, yeah, nail beds, so somebody's darker skin. Come over with me. So, and then, we are great on therapeutic communication, I'm telling you. All of that. So, you think of like how persons and their families dealt with stressful situations in the past. I don't know how this is always gonna realistically transfer, because it's really stressful. So there's sources of strength, any cultural factors. So our usual therapeutic communication, you know, always is gonna be have the person talk about things and ventilate. So permission to grieve, so that one would be things like, remember, it's not a fluid process. They're gonna go, you know, through waves of, you know, feeling acceptance and going back and forth. It's just like, you know, I hate to say, we've all have, unfortunately had issues that we grieve about something, and it's not just, you know, I'm gonna go through the 5 stages and ready for action. That's not how it goes. And then agencies that can help with the grieving process, like, you know, cancer support groups, you know, something at your church, therapy. Read my own slide ahead. So, American Cancer Society, but spiritual leaders and support groups, but cognitive therapy, great too. And then, of course, the old leukemia information. So, but then there's a whole, you know, there's a separate leukemia and Lymphoma Society, which is where I fact checked a lot of our stuff here, and get on that website too. So not just cancer.org, I should have updated that, but the whole Leukemia and Lymphoma Society talking about multiple disorders, you know, the World Wide Web, you know, life's ahead of us. Yeah, it's a little early. Well, listen, we gotta just stretch right now. Stretch till 7. Hodgkin's and non-Hodgkin's. So before we even start telling you, big thing with multiple myeloma is gonna be bone issues, bone pain, and pathologic fracture. So same objectives, you know, be able to tell the difference between these three and then the leukemias. So easy enough, these are gonna affect lymph nodes. Myeloma is the bone marrow again, but Hodgkin myeloma is gonna be bone marrow, and it's gonna affect your humoral immunity. And then Hodgkin is lymphatic cancer. So how they're gonna look at the person, how we diagnose them, medical nursing care, and the nuclear nursing care thing. So get multiple myeloma, plasma cells get infected, and they're gonna infiltrate bone marrow, lymph nodes, spleen, other tissues, but plasma cells are the B lymphocytes. So that's humoral immunity. So you're all, you know, there's always a question like this, just like we talked about the other cancers. You get more into statistics, but the biggest thing is, so generally older African American men, if they go that way. So African Americans more than Caucasian people, and then men more than women, and generally over 40. So pretty poor prognosis, chronic, and there's exacerbations of it. And the end stage is going to be pancytopenia. This means everything's low, hemoglobin, white blood cells, hematocrit, platelets, and then organ infiltration by myeloma cells. So remember what happened, organ infiltration with leukemia with leukemic cells, now it's just myeloma cells. But our same issues, bone, like I said, bone plays a big one here, but our same infection, bleeding. So largely unknown etiology, but can be with family history, can be a virus that initiates an oncogene, chronic inflammation, we know all that's bad, and the thing, good things that cause chronic inflammation. UTI, but even more global, diabetes, obesity, autoimmune diseases.
So like RA, like that kind of stuff?
Mm-hmm. And then, yeah, and antigenic stimulation, so other autoimmune things. So normal physiology review, so this is attacking, again, the B cells. So multiple myeloma, MMB. Another thing, I feel like that's really sometimes. Multiple myeloma and B cells. So it's not going to be T cells. T cells are cell-mediated immunity. This is humoral immunity, longer lasting. So what happens is malignant plasma cells, and they're going to produce this immunoglobulin M protein. So M protein's present with multiple myeloma. Easy enough. Third M. With multiple myeloma, you get this M protein. Impaired humoral immunity. So since my humoral response is suppressed, I get recurrent infection. So the T cell, the cell-mediated immunity is intact, but we did them both working together for normal immune system. So this M protein also increases viscosity of blood and can damage renal tubules. So what's that mean? If my renal tubules are damaged, ultimately it's going to affect my renal function. So I'd be looking for increased creatinine, abnormal findings in the urine. coming up later, but another marker you can write down right now is, they're called Bence-Jones proteins. It's gonna come up later.
BNTZ.
Bence, like fence, but with a B.
Oh.
It's written. Bence, yeah, Bence-Jones. What's the law firm? So, this should be a comma there, I'm so sorry. So as myeloma cells proliferate, comma, they infiltrate the bone marrow. So you really get a punched out appearance of the bones for X-ray, like these big pockets of lacy looking bone. And you think, that's the matrix or bones. If I have these big lacy areas, then that's how the fractures happen. They just can't support any weight or stress. The cortical bone is progressively lost. Both the tumor and, the tumor meaning the tumor cells and the enzymes that the myeloma cells produce. So it's going to be vertebrae, skull, pelvis, femur, clavicle, scapula. And I swear, I thought I reworded this. I hate do this so many times. But so spines are going to have compression fractures in the back. So bad back pain can have rib fractures, and so what's that going to be? Intense pain when you take a deep breath, very bad pain when you take a deep breath, and then bones in the extremities. But it can be pelvic problems too, pelvic fractures also. Like I said, bone pain, think multiple myeloma is going to be bone pain, and obviously, as the disease progresses, it's going to get worse and more localized. So you get release of calcium from the bone, so you can get hypercalcemia. So with hypercalcemia, what do I get?
Dysrhythmias.
So cardiac problems, and what else did we say? Right, so mental status changes. Think abdominal pain, you get with hypercalcemia. I totally said the wrong one, because this is not, I'm very mad at it. I'll live. I'll be irritated the whole time. So, who cares about this picture? But, okay, Bence-Jones proteins. So that's what can lead to renal failure. So we know lab-wise, but is a person going to have a normal urine output if I have renal failure? No, so decreased amount of urine output.
So the Bence-Jones, they're the ones that swell up?
Well, they just damage the tubule.
Okay.
And then there's this, it's hard to see on them, so it's, in the skull, you can see they have little darker circular areas. So that's the point.
So the fluid can be like thick, and then this with that protein present. Can they both, the N protein and the Bence, be present at the same time?
Yeah, yes, but it's just the Bence-Jones, it's just the finding that's in the urinalysis. So in the UA, they have Bence-Jones proteins. That's kind of like the hallmark of multiple myeloma. Coming up on it. Written better, but those M proteins are present in their blood too. So in the blood, it's going to be the M proteins, and the urine's the Bence-Jones.
Okay.
And then bone marrow examination, so abnormal number of immature plasma cells. So thinking about that, to diagnose it, what are we going to do? CBC, so they're going to be pre-anemic, so low hemoglobin and hematocrit. It have presence of M protein. And another one is beta-2 microglobin. It's just present with multiple myeloma. In the UA, has a Benn's-Jones protein. So even though it's a UA, patient teaching wise, you're still gonna tell them to do it like a clean catch, midstream urine. So don't need to do a 24-hour urine, don't need a straight capital, but just midstream collection. And then biopsy the myeloma lesions. So how am I gonna biopsy the myeloma lesions?
With the bone biopsy,
Right, yeah, with a bone marrow aspiration.
yeah.
So no cure, but, so chemotherapy is gonna control progression of the disease. So hopefully that there's not such bad exacerbations. Supportive care to reduce complications, so that's like hypercalcemia, like pathologic fractures. And then right in there, because I have to do this slide a million times like I'm crazy, I redid it properly, is pain control. It's really appropriate pain control. It's big, bone pain is a big problem here.
Can you give an opioid for that?
Yes, opioids and other classes, but definitely opioids along with other classes, because there's going to be complex pain to treat. So big complications, again, is going to be hypercalcemia and fracture, and then good pain control, and obviously, supporting end of life things too. Definitely writing pain control, which is really written in my right slide. So don't even worry about this melphalan. Yes, it's an agent that you use, but I want you to throw another agent on there. Just think with cyclophosphamide, which is Cytoxan. And those adverse effects are general chemotherapy ones. Nausea, vomiting, alopecia. Immunosuppression. And then prednisone is going to be what?
Anti-inflammatory.
Right, anti-inflammatory because it's bone pain and adverse effects like poor wound healing. Again, yeah, it's gonna, so now increasing my infection risk. So now, again, like getting chemo, now I got another thing to worry about.
What about NSAIDs on this?
Yeah, there's something to do NSAIDs,
Hmm.
but again, you gotta be careful because of their renal status and their bleeding status. And prednisone does what to your blood sugar? Right. Always gonna happen. And slide is incorrect. This is why I took it out. I sent the wrong one, so I usually get printed. Cross that out. Chemotherapy does not help with any of that. Yeah. Well, the localized radiation, that is true, but that first bullet is incorrect. I'm so sorry. Sent the wrong one. But you think localized radiation, and think about our same problems with radiation, it's still gonna affect their skin, so skin changes and the whole, no perfume soaps, no harsh towel, like patting things dry. And this one needs a little room formatting too. So supportive care. So you think you have bone loss. So alendronate, Fosamax is good. Typically they use another drug, and that's okay. But just stick with bisphosphonates, bisphosphonates. Really, that's not the drug that they use. But we already know bisphosphonates help with bone loss. And think back, what's really important about those? teaching wise,
Remain sitting.
yeah, you have to be able to have an upright posture, because they can cause esophagitis, distal esophagitis. So they have to remain sitting up after they take it. And then another weird one, it can cause necrosis of your jaw. So they have to get a dental exam before they start it, and any problems, like with chewing or bad dental pain, they usually stop the therapy. So I know it looks weird, so I just separated them, because if they're hypercalcemic because of involvement with the disease, it's gonna be our same thing we do for hypercalcemia, which is what?
Fluids.
Yeah, hydration, test-wise, Lasix, but also bisphosphonates for hypercalcemia. But to help with bone loss, that's when you would do the calcium, vitamin D, and fluoride to support bone structure. Again, it depends on the patient's situation, and we're not gonna have a patient situation, we're thinking about a test scenario. Which is balanced, again. Sorry to keep apologizing, but really, it's not the way I want it on there. I don't want it to be confusing for you. We're gonna treat hypercalcemia one way, but in general, we are trying to support their bones for as long as we can. So, stupid line, all infections of the treated product, stupid, taking that out. So doing plasmapheresis, that's to get rid of the M proteins. I think that's those are the proteins that are causing the problem. They also do, for multiple myeloma, they can do stem cell transplant for myeloma also, to try and help slow the progression. So that's what should be written in there. Could also do stem cell transplant for that, and it's gonna be our same things we already talked about, doing it for leukemia, like the same nursing considerations and method of doing it. So, health history, so back and bone pain, onset, duration, intensity. Again, we're thinking of this person, older, male patient, so they, again, weakness, fatigue, can have a lot of recurrent infections. Then paresthesias, clumsiness, and that's just because, again, you're having all these big lacy lesions, it's going to affect your nerves also. So, doing their exam, checking their level of consciousness and mental status, in case of what? That they have hypercalcemia.
Yeah.
Right. So their mobility and gait, again, we really want to protect that, because they could have limited mobility and problems with gait because of, osteopenia, their bones are weaker. So localized tenderness or pain, and this PMS, I'm like, what in the heck does it mean? It's pulse, motor, and sensory, but you just think of it as a neurovascular assessment. So pulse, motor, action, and sensory, but our whole neurovascular assessment. So checking for capillary refill, checking our range of motion, so chronic pain, impaired mobility, risk for injury. So pain assessment, so let's get to the position of comfort. So you might have to use pillows or wedges, something, because you think they're going to have really a lot of pain around their joints and around their bony prominences. Get it? Patient positioning. So that's something really all on us. So it's important you want to focus in on. See what their position of comfort is. make sure they get proper rest. And always, you know, we're definitely gonna medicate them, but the non-pharmacologic pain things. So heat could help, like,
Is it any colder now?
well, I'll tell you like this, test-wise, no, but real life, yeah, like whatever's gonna help the person feel better. But test-wise, it's gonna be a no.
So it's just like heat.
Heat and the positioning. And of course, about, you know, then when we get to analgesics, we're going, you know, we want to get to the pain before it gets severe, so before it gets to a severe level. B isn't true, because these people have terrible pain, so you just want to educate them that, you know, addiction isn't an issue here, because they're having terrible pain. So, you know, we're not worried about addiction, we're worried about treating your pain so you can be comfortable and be humane. And we, like we've said a million times, you might need other drug classes in addition to opioids to help out. Like anticonvulsant medications, benzodiazepines could be, what else? Muscle relaxants, like whatever is gonna help out. But it's not just, you know, if an opioid isn't helping, it's not just keep increasing the dose of the opioid. Because what's the big problem with high dose oral opioids?
Yeah.
Well, eventually CNS depression, but just
Respiratory.
GI-wise.
Oh.
Constipation, really. And this is somebody you think is not mobile already. So if they're constipated and not mobile, what could happen? Obstruction, yeah, perforation, bad nausea, vomiting just from being so constipated. So, since they have problems with their mobility, again, remember, we're repositioning people at least every 2 hours. And, you know, it's even going to go to every 1 hour if they're really having signs of breakdown. And what's going to be signs of breakdown? Early on.
Redness.
Yeah, so erythema that's really slow to blanch. So they use a trapeze, and again, updating it to the 90s. What else are they going to use in the hospital now? They're just lifting equipment, like different mechanical lifting equipment. So you're not pulling the patient. Just think, if I'm pulling them, what am I going to maybe do?
Shear.
Well, skin problems, and think, I have this lacy bone. If I pull somebody, I could break their arm, literally. Like I break their arm, I could break their rib. They have pathologic fractures, even moving around in bed, like they could turn over and break something. That's how bad it gets.
Mm.
So sliding board, even low, that's low tech. So, and then fall, this seems very common sense, but it's not. Like, you don't want the person trying to reach for something and then falling out of bed. So our usual bed to low position, side rail, so, and if there's a place, remember the 4 side rails can be a restraint. So what else can we use? Just putting up 2 side rails. We're gonna do that, keep them safe. There was somebody who's hard-headed.
A bed alarm.
Bed alarm, right, like, they could be cognitively with it, but they just, I don't wanna bother you. Well, bothering me is, when you break your hip, that's really gonna bother me, so.
Maybe a landing strip.
Or you just, you know, because, you know, and at home, they might have a little whole system hooked up. They're using things to reach, like they have a whole list of little stuff around them, but we wanna keep, you know, a clutter-free environment too. And our usual call bell. So, non-skid slippers. Like I said, adequate lighting, making sure things aren't cluttered. At home, it's gonna be throw rugs. So walker, because, you know, a cane, yeah, a walker's gonna be more stable than a cane, even a quad cane, because it's, you know, bigger surface area.
What are the arrows for?
Because again, this is some goofy picture I took out. I took out the arrows already. I took out the arrows on my thing. I just saved the wrong, I used the wrong one. So then home care is not any different. It's gonna be the same thing they're doing in the hospital, just adapt it to their home. Cut it out. I cut it out before. So there's nothing special about home care other than, you know, clearly, they're gonna have probably more fall risks at home. You know, more things to maybe trip over, more rugs, okay? And we're telling the patient about inside the infection, so we know. Low fever, cough, sore throat, urinary symptoms. So now malignant lymphoma. So now, this is our lymphoid tissue, so proliferation, lymphocytes, histocytes, which are just precursors to lymphocytes. And there's two types here, so Hodgkin and non-Hodgkin. And again, this is an overview. There's 60 different types of non-Hodgkin. So don't drive yourself crazy. Keep it basic, just like we have. So risk factors, this is a biggie though. Immunosuppression, so anytime you're on immunosuppressive therapy, you're at risk for developing lymphoma. So if somebody has an organ transplant, HIV positive, but what else? What else would you be on immunosuppressive therapy for? Right, yeah, autoimmune disorders, so rheumatoid arthritis, even the inflammatory bowel disorders, all those, so it's really a big concern. Anytime you're on immunosuppression, because what's it doing is suppression those cells that would normally kill altered DNA cancer cells. We already said Epstein-Barr and the T-cell leukemia lymphoma virus. This is the Epstein-Barr, that T-cell lymphoma leukemia virus was hit before. And then occupational exposure, so they're working herbicides, like if they were working in a greenhouse, gardening, very know, chemicals in general. So there's two occurrences of Hodgkin's, teenagers to early adulthood, and then over 50. So one most curable, Hodgkin's is. So it develops in a single lymph node or chain of nodes and then spreads. So our big thing, Reed-Sternberg cells with Hodgkin's disease. Non-Hodgkin's doesn't have Reed-Sternberg cells. That's the defining thing. Aspect, shouldn't say thing. And the malignant cells secrete inflammatory mediated substance, and you're going to have inflammatory cells to the tumor site. So that's important because what happens with Hodgkin's many times is this, again, a swollen, non-painful lymph node. Spleens involved initially, and then it progresses lung, liver, GI tract, CNS. So when we're saying that, that means what? If it's going to our liver, then we're going to have jaundice, increased LFTs. Going to our lungs, we're going to have cough, respiratory symptoms. GI tract is going to be things like occult bleeding, inflammation, swelling, and CNS, change in mental status. So here it's affecting our T cells. So multiple myeloma was B cells, now it's T cells. One more time. Cervical painless lymph nodes. And our usual, back to the beginning, so persistent fever, remember that happens with tumors, night sweats, weight loss. Later diagnosis, malaise, pruritus. Pruritus gets to be pretty major, so we'll talk about that in the intervention part. and anemia. On your little thing, so it's just like a little cartoon, hope you remember it. So that's all Hodgkin's. Non-Hodgkin's really is just the age group it affects, so it can be older people with non-Hodgkin's. And obviously, like, unfortunately, there's exceptions to this, but we're just, keep it like this for test-wise. So it can be older people with non-Hodgkin's, and it doesn't have the Reed-Sternberg cell. But like I said, 60 different kinds, so don't. Keep running.
Can young people get it? I'm sure they can.
I'm sure they can, but we're gonna keep it with older people. I don't even, but I know of people who haven't non-Hodgkin's care. So, can develop, non-Hodgkin's lymphoma in different regions of the body, but it can be unpredictable. The same thing is gonna spread throughout the non-lymphoid tissue. And prognosis, and I stated this better, but it's gonna be unusual. If it's low grade, it's gonna be well differentiated, less aggressive, more curable, and high grade, poorly differentiated, poor prognosis. Not new. That's not really my star. Because I know you know that. But presentation-wise, it's going to be that painless enlarged lymph node. And it can be diffused for non-Hodgkin's. It's not just going to be the neck, it's going to be lymph nodes all over. So where are other big lymph node sites besides your neck?
Groin.
Right, so groin, yep, axilla, so there's chains all over. And really that large is just, a clump of lymph nodes together. So, but it says less common, it happens. So organs involved, GI symptoms, so abdominal pain, nausea, neurologic symptoms. So here, peripheral and cranial nerve symptoms. So start this one, so you gotta remember those cranial nerves again. But that's good, because they'll come up with stroke too, so just helping you out.
Oh, yeah. What's that, like the paresthesia and stuff like that?
No, like say if it's, non-Hodgkin lymphoma, person, they have non-Hodgkin lymphoma, they come in, they have a right-sided facial tumor. What cranial nerve can that be? Unfortunately, it could be that they're having a stroke.
Okay. What about peripheral stuff? Like
Peripheral is just gonna be, it's just gonna be really paresthesias.
Okay.
So, our usual CBC with differential, but here they're gonna need a lymph node biopsy. And so that can be, fine needle can be done kind of like in a short procedure, or if it's extensive, but generally it's gonna be a short procedure, sweep. So you would prep them just like for any operative procedure. Meaning what? You're gonna get baseline labs for everybody. What else do people get pre-op wise? Well, yeah, MPO, we'll prep them. What else do they get? They do get washed down, we'll get labs. Any adult patient they get a chest X-ray, they get an EKG, tell them about that. Yeah, they're definitely gonna be MPO after midnight. What else? Say again? Yeah, well, yeah, they're gonna make sure their history's up to date. What else is some of those bloods? Make sure the typing screen's active in case somebody nicks something. You always get a UA, just to make sure nothing's bad with the urine. They get a chest x-ray, because that's a kind of a pre-op thing, but chest x-ray here is to make sure, I'm not having, inflamed lymph nodes at my mediastinum. But I'm sorry, I'm hopping around myself. With the lymph node biopsy though, are they gonna bleed a lot per se?
No.
No, it's really just gonna be needle, get a core, in and out. You're still gonna check the site, obviously, just checking for any signs of infections post-operatively, but
So, type in screens for any procedure?
generally, yeah. Now, and if it's a high risk or bleeding, then I'm getting type and calls. But you said all great things, like you said, MPO, maybe some type of surgical scrub, he'll be doing that at home. Consent, obviously, make sure the consent's there, they're coming from the outpatient area. So check chest rate, checking for nodes to the mediastinum. And now for staging here is gonna be, you can do it with the lymph node biopsy, but they might have a kind of where you're going. So the usual IV access, check their creatinine, BUN, assess for shellfish allergy, iodine allergy too. Those are all the classic test ones. Real life, generally you ask people if they have really severe asthma too, because having severe asthma, the contrast dry can be a trigger for that also. So if you ever have one and they ask you that, that's what that's about. So non-Hodgkin's, it can remain normal until late in the disease, and then they're going to get pancytopenia. And then with Hodgkin's, they'd have anemia earlier on. That normochromic, normocytic, again, is it talking about that, those, red blood cell indices. And this slide truly is nice, and I'm not gonna ask you this. It's gonna have a high neutrophil and elevated sed rate. Because a lot of things can elevate your sed rate. I'm gonna take it out, but, because we just know we're checking their CBC, which you already know. So like I said, chest x-ray, checking for mediastinal lymph nodes and pulmonary involvement. And they could have a CT of their abdomen, chest, and checking to help with the staging process. So the CT for staging process. So don't worry about those monoclonal antibodies. Again, that's great, nice to know. I'm not gonna ask you tons about those. I'm not gonna ask you anything about that. We know we're having chemotherapy and radiation together. For monoclonal antibodies, it's just puts you at high risk for infection. Pinky swear, nothing about that. And you can't see this, but it can be so large, the lymph nodes can be so long that it causes tracheal deviation. Then I did leave this one in though. You can see how enlarged your lymph nodes are to the whole pelvis.
Wow.
So they try and get the largest lymph node to diagnose, and again, that's gonna differentiate between whether it's Hodgkin's or non-Hodgkin's, because the Reed-Sturbeck cells are in the Hodgkin, not non-Hodgkin. And staging, so how do you tell the staging again?
TNA.
Well, by the CT and lymph node biopsy. And then, not being smart, but don't, remember, think, for 2 and 3, don't worry. 1, you know, is gonna be better prognosis, localized to 1, compared to stage 4 is diffuse. So, just know the 2 poles of them. 2 and 3 are nice too. Nice to know.
So what should we know? I'm sorry, I was,
1 and 4.
thank you.
And it's kind of, but it's things you already know, you know, 1's milder, 4 is terrible. So, combination chemo, you already know, multiple agents to minimize toxicity. Cell cycle, non-cell cycle specific. If you do the radiation first, then that's gonna be what? To shrink the tumors, but that's the neoadjuvant, like you're doing something before the chemotherapy. And this one I definitely cut out. There's way too many combinations of chemotherapy. Don't worry about them. Stick with, again, when you look over your meds used in oncology, like their second slide packet, just stick with that. I'm not asking these various combinations, because it's too individualized for the patient. Don't worry about the different combinations. So, I got this one because it's a duplicate. This is not my final product. Just worry about ones we've hit 1,000,000 times. So cytoxin, we just talked about that one. That's all the generalized, nausea, vomiting, alopecia, neutropenia. Doxorubicin is gonna be always,
Cardiac.
yeah, cardiotoxicity. So baseline EKG, telemetry monitoring, looking for worst problem. Vincristine's gonna be neuropathy. So remember things like stepping on crystals. So peripheral pain.
Then Christine and Cisplatin for that, or no?
Yeah, cisplatin give it to you a little bit. And then prednisone, you know, is a corticosteroid, and what's that doing?
Right, elevate your,
Yeah, suppressing inflammation, so you increase your blood sugar, and our added benefit with oncology patients is it helps with that nausea. Remember, it's an antiemetic for oncology patients.
That's what dexamethasone.
Yeah, well, yep, Decadron. Yeah, I'm sorry, it does say prednisone up here.
yeah.
The Delazone is,
So it's not an antiemetic, right?
prednisone isn't, but Decadron is.
Decadron, yeah.
It doesn't, it just in oncology people.
Is the prednisone Delazone?
No, not that I ever heard of.
Okay, so we crossed out prednisone then?
No, just cross out the Delazone.
Oh.
It's a very old brand name that no one ever uses.
I am right. I'm not
Everyone
that
calls
old.
it just prednisone.
I've never been seen it, so
That's not an antibiotic.
it's not.
Okay. But the dexamethasone is also a part of the combination.
Dexamethasone is commonly used in combination chemotherapy. I'm sorry, again. Cut out this weird picture.
We need to know the other ones, bleomycin? No?
Mm-mm.
Okay.
Do the ones we've done 1,000,000 times. So radiation therapy, and so think, now it's gonna be generally it's gonna be, you know, if they've done that central biopsy, they're gonna do it where most of the lymph nodes are. So that's why it's try and do it when it's earlier in the course of the disease. Because we wanna shield unaffected areas to minimize burn and cell destruction. So you can do total body, but think, if I'm doing my whole body, then what's gonna happen? I'm gonna have big systemic effects. So more fatigue, and then really it's gonna be bone marrow suppression, or everything's gonna be worse if I'm doing my whole body. So sterility is common. So that means what? Before you start, therapy, whether it's Hodgkin's or non-Hodgkin's, it would be bank their sperm, freeze their eggs. And our usual bone marrow suppression things. And secondary cancers, because of having chemotherapy, you think that always means if I have cancer in one area, unfortunately, I'm at high risk to develop cancer somewhere else. And the cardiac injury is with the doxorubicin and different chemotherapeutic things, both. So thinking about this patient, really our big thing is this enlarged, non-painful lymph node. And fever, put in a comma, night sweats, weight loss, fatigue.
You don't like my Corona?
Abdominal pain, I'm gonna read them all to you. But a history of mono and HIV disease, just because mononucleosis is gonna causes lymph node enlargement a lot of times too. But with mono, they tend to be tender lymph nodes. And doing our usual physical exam, so nothing's on here that we don't know about. Subclavicular, you have there too. And palpate, if you can palpate somebody's spleen, it's really a problem. It's not normally palpable. And then our usual emotional support. So we worry about if our bone marrow suppressed, our usual, not only infection, but still the thrombocytopenia. Nausea, body image. So if they're really tired, so you actually, want to use therapeutic communication, their feelings, a quiet activity, make sure they're getting good rest, and delegating responsibilities. Say it's a younger mother who had developed it, or younger father, doesn't matter. So they're getting, having support. So enjoyable, quiet activity. I'm telling you right now, there's one question on there that's stupid, I'm taking off the test, but that was like, what are they gonna do for activity? Jog or, play Monopoly.
Leave it on.
Yeah, you should say that.
No.
It was an oops, I left it on there.
Those are the fluff questions that help us.
We need a lot of
Too
fluffing,
smart
I'm
for
just
it.
saying.
Too smart for it. So then, again, I hate to keep apologizing, but this is all jacked up, not what I wanted.
That's like an extra point.
So how do we help with nausea and vomiting? Crackers, hard candy, I didn't leave stuff on hard candy, it's a little provocative. Our same bland foods, don't eat right before chemo, that's an oldie. Give the antibiotic before chemo, that's an oldie. Try higher carb, high calorie, high protein, just trying to get it in there. If the fluids aren't going to fill them up, but if all they can tolerate is fluids, fine. There's always nutrition left. Our usual small pre-prep meals, making sure about the oral hygiene. And again, I took this off too, stupid. Sit up to eat. Unless you're a snake, I don't know. So body image-wise, you take these many times, because what can happen?
Could have incision scars.
Well, incision, alopecia, things not just your hair, but all the hair, your eyebrows fall out, your eyelashes fall off, baby. So understand the limitations by their illness or treatment. So you're gonna think, if it's a younger person who's really active, no, you can't go you know, even if you're doing better, you still need to avoid crowds. You can't do those, you know, like you couldn't do horseback riding or play lacrosse, like, even when you're feeling better. You know, to make sure you're totally in remission. So how would they know if they were in remission?
They ask.
Not really, by the blood work. And again, our usual therapeutic communication, discuss your feelings, and personal. And we hear a million times about wigs and hairpiece and extensions, whatever they want to do. Nothing's going to be different at home. We'll do the same things at home that we're doing in the hospital, it's just that we're teaching them about that. So it's going to be, you know, how do I know the teaching is effective? Yeah, whatever it is. So, finally, because I had this up earlier, so you do want to think about itching, like, because, again, with the skin issues, if they're scratching a lot, they could cause a break in their skin integrity, and then that's a portal for infection. So, it sounds silly, but making sure their nails are cut short, they're not using things to, like, you know, dig at them back or whatever, you know, because people do weird things, you know, they scratch themselves with forks or whatever. And again, having that big open area to your skin is the portal for infection. And what's that going to be? If I have compression, I don't think this was on the, that's not even, that should be even, messed up.
Should be an
The vertebral
esophageal.
compression is going to be with what? Let me know the right one. Who's going to have vertebral compression fractures?
The myeloma.
Yeah, multiple myeloma.
Yeah.
So not on the right one.
Sorry, it's wearing off.
But think about it for multiple myeloma.
Yeah, but on that slide.
It is, but I'm saying. On the right side.
No.
Sorry about that.
It's all right.
Okay, breaking time.
Station is the pathologic process, hemorrhagic and ischemic stroke. Explain rationales for relevant medical interventions in treatment of patients with stroke. Discuss emergency management, look at the complications, and also develop a teaching plan.
Do you have an extra
Oh,
PowerPoint?
did I not give you one? Sorry.
No, stop.
Did you take it? Did not like it?
No, he's been cutting it, making it for everyone.
Oh. So when you look at stroke, these are statistics, it changes all the time. The big thing is, it affects a lot of people every year. And one of the key things you see is people are getting younger and having strokes. So the big question is, why do you think younger people are having strokes?
BP.
BP, why
Crappy
do they have high
foods.
blood pressure?
Poor eating habits.
Obesity.
Poor eating, obesity. You know, as you do more clinicals and you see type 2 diabetes is always like older people, like middle age or that. You see 16-year-olds with type 2 diabetes now. So poor eating, high blood pressure, obesity is a big thing. What else can,
Stress.
stress is one. Smoking is a big thing. So not just smoking, although smoking rates has decreased, vaping has gone up. So, you know, we're moving, you know, one thing for another that still causes it. So you can see like 185,000 for recurrent, risk doubles for every decade after 55, and then 2/3 of all strokes occur after age 65. They're getting younger and younger. Like, when we opened Einstein Montgomery, I was surprised how many strokes we had in younger people. They were healthy people.
I had a coworker, he had a stroke, he was 28.
28,
So
yeah,
he
you
had,
see them, it's
Yeah.
crazy what you see. And some of those are, did he have any medical problems?
No, I mean, he was a little, he was like really stressed out, but he did put on a little weight and stuff.
Mhm.
And I think he did smoke as well,
Yeah.
so.
Little things like that. And the other thing, you know, some of the ischemic strokes can happen from increasing blood pressure. So not just high blood pressure, but all of a sudden you have this sudden decrease of someone. We used to, when I first started nursing, we would have patients with pressures of like 210 over like 110, and all of a sudden, boom, we're dropping the pressure down to like 140. Well, you think of, you need that pressure to get to the brain because you have all these occlusion of arteries. So all of a sudden, we found out when we drop it too low, all of a sudden the brain's not getting that blood anymore because it doesn't have any pressure to get up there. So we were causing stroke by the way we're treating
Is
it.
that just when it like suddenly drops that will happen? Or is it like if you have just like a constant blood pressure?
You can with the constant, so if you think of what we look at max, anything less than 60. So it goes with anything with perfusion. You know, the nice thing with perfusion is, first thing your body shuts down is what? Kidneys, you think it works its way up, all to preserve the brain. So with chronic low hypotension, and that's less than 60, yes, you're gonna have hyperperfused areas. Maybe not a full-blown stroke, but you're gonna have some problems with that in there. So when we look at all these, the prevalence and all these stats, just some stats just to see how big and how many people this impacts is like only 10% of the population are going to recover totally. That's only a small population. And this is all strokes, whether it's, you know, a small stroke, a big stroke. 25% with minimal disability. 40% of both people that have strokes have a moderate disability. And 10% need long-term care. So when you think of that with the aging population right now, especially the baby boomers have it, where you need a lot of long-term care to take care of them. And then 15% of patients that have strokes are going to die suddenly after, or soon after, not suddenly, but soon after. So the biggest population is moderate defects, and a lot of these people will never go back into the workforce. I worked with an ER doc. He had worked with Georgetown for a long time, and he rode his bike. He was an avid bike rider, you know. Unfortunately, he was hit by a car. He had his helmet on. He had everything. And we learned about, and we'll learn more about trauma, things that are going to cause strokes and hypercoagulated states. Trauma is one of them. So he ended up having an embolic stroke from a thrombus, and it went to his head. So you talk to him, he seems great. He's not talking anymore. He doesn't have, at the first sight, it looks like he's fine until he gets closer trying to pick something up, and you see like he doesn't have the fine motor movement. And when you talk a little bit, you know, he looks at me, like, I know I know you. Even though I worked with him and then didn't work with him, I've known him for 15 years. So it's kind of hard to, you know, forget people, but he couldn't place it, and you could see things missing. So you think he's in mid-50s, and all of a sudden, how long is he going to live for now? That he can drive and do things, but now he can no longer do his job. So that has a big impact on society and livelihoods of everybody. So just before we go into that, I don't know if they're in here, I was cutting and pasting, I'm just going through really quick. I figured out why I couldn't send it to myself. I blocked my own email address from home, and I just figured it out. So what I think, I didn't change it too much, but I wanted to make sure I gave it to you. All right, so stroke definition. When we look at the definition, brain attack is one of them. It's a sudden decrease in blood flow to the brain, resulting in a neurodeficit. And it can be caused by a hemorrhage, it can be caused by a thrombus formation in there, and it can be an embolus. What's the big difference between a thrombus and an embolus?
One moves,
Exactly, which one moves?
embolus.
Right, an embolus. So an embolus could be a clot, it could be plaques that break off somewhere, it could be any type of piece of something or other, calcification, something like that that moves. Neurological deficits vary, and they're going to vary to the point, or to the area of the brain that's involved. And also the size, and that's going to be important when we go a little bit more. So we can have very small area, the best pictures, which is to show, and we'll go over more, you're not the diagnosis. They're showing like the areas you can see the ventricles, how they're a little bit different in the area of stroke. You can see a little, maybe a small area, a hyperperfusion, someone have a stroke, maybe in the occipital lobe, but it's so small, but where it's at, it can cause visual disturbances. Where somebody could have a larger area, like over in the temporal region, well, what's really over there? You know, when you look at that, they have a larger area, but they don't have as much defect. So it's not just the area of brain, it's the size. It's not just the size, I should say, it's the area of the brain. And the length of time that the blood flow is decreased or stopped. So a little bit more of the definition, ischemic and hemorrhagic, and we'll get into these a little bit more too. So ischemic, the blood supply is interrupted, result, like I said, a thrombus, embolus, or a blood vessel stenosis. And usually that area is like over here, the clot stops, it's gonna be somewhere, so you'll see this, like, they call it like a hypoperfused area, and we're gonna get in a little bit. Did you guys go over MIs at all? Did you learn about that? And I
Yeah.
didn't know if you had like cardiac, yeah. They talk about the zone of ischemia, injury, and
Mhm.
infarct.
Mhm.
So take that principle, apply that to the brain. You're gonna have the same thing. You're gonna have your zone of ischemia, you'll have a zone of injury, and then you'll have an area of infarct. So those same principles, so you can see time is brain, the longer it's without blood, the bigger the area is gonna get more damage. So the same principles apply there. Hemorrhagic is gonna be the rupture of a blood vessel, and it's gonna spill into the surface spaces around it. So what are some things that could cause a hemorrhagic stroke? Trauma, right? Aneurysm burst. Right, and, and aneurysms, I should go into what could cause an aneurysm.
High blood pressure.
High blood pressure,
Smoking.
right, smoking, so you have the weakness in the wall, could be congenital with all those, so, any of those things can cause a hemorrhagic stroke.
A lot of the aneurysms, you can have them all your life and never know.
Right.
They're just, you're born with them.
When I was out in, when I was in Utah, I was teaching our director, we were working, and her husband was, I think, trying construction, something there. They called, got him to the hospital. He said it's usually the worst headache of their life. He heard a pop.
Firecracker.
Fell popping sound, and they drove him. And I'm going back, oh, this is something of course. We're going like it was between 2000 and 2004, so that's like really long ago already. But you think, wow, and they got him to the University of Utah, they put a bullet in, they did it. And back then it was kind of like people died from infection because we don't like to put bolts in and drains in the heat. It's not really sterile or anything, but to save his life and stop the bleeding, Murph went back to work, he was back to his construction job, riding horses. It's amazing how he did that, but it was the classic that you read in books that they feel a pop or they hear a pop, or, what did you say, firecrackers?
It's a fire, yeah, that's what a lot of patients say.
The crackling, and they feel or see something, and it was just that person that got him to the hospital quickly, found it, or, saved his life really with that. So risk factors, there's a lot of different risk factors. And then with this on your paper, you can go ahead and maybe divide it, let's look at modifiable and non-modifiable. So those are the big things to look at. So let's talk about non-modifiable. What are some things that we cannot modify?
Family history.
Right. Family history, age, race, sex, right, they're non-modifiable ones. What was that?
It's kind of modifiable.
What's that? That's fair. Good point, yeah. And, go back to the sex question. Yesterday and today, sorry, the transgender, because yesterday and then today they did some, and he said, good question, he never really thought about it.
Oh.
Because with the female to male, they are taking the breast tissue, so there might be a chance, he says anything possible. With the male to female, they take low dose estrogen, so it's not much, it's low dose but more than what males have, so he doesn't think he'll put it at risk, but he really didn't have an answer, because no one really asked him, because that's usually not a concern of theirs. So if I see him again, maybe he'll set up. That was the question we were talking about, breast cancer, all that.
If there's even any research.
I don't know.
It's probably fairly new.
I don't know. It might be, I don't know. Okay, so with the non-modifiable, African Americans are 2 times greater than Caucasians and other races of having a stroke. Latinos and Latino and Hispanic are at higher risk of ischemic stroke at an earlier age. And they're also higher risk for subarachnoid hemorrhage, which is kind of interesting when you look at the different things that way. So some things with sex. So females are at higher risk because of certain things. So younger females. Why are younger females more at risk? Mm-hmm. Birth control was a big thing. Birth control, and there's always new ones on the market, and they come off the birth control, pregnancy, and childbirth. There's a higher incidence, hemorrhagic stroke after childbirth. Menopause puts them at risk, so heart disease and stroke are almost neck and neck now for the killer women. And some migraine headaches, especially if they have an autoimmune disease like lupus, puts them at higher risk. More women have lupus than an autoimmune disease than men. They think that they're at risk for having more. What are some modifiable things that put you at risk?
On this slide? Or what are you talking about?
No, still for the risk of stroke.
Like lifestyle.
Right, they totally missed modifiable and non-modifiable in the lecture, so tried to modify this a little bit.
Gotcha.
Failed miserably. Smoking is one.
Hypertension?
Diet, hypertension, weight, weight's a big thing. Diet would be low in red meat, low salt.
Active sedentary
Right,
lifestyle?
sedentary lifestyle, look at how many we have, how many online jobs, and how much have we sit now compared to other things. Diabetes is another big thing, is that on there? I said, medical issues, I should say, family history, stroke, recent viral or bacterial infections, no, maybe let's not, like, that shouldn't be at the top, that's on there. Hypertension, sickle cell, why sickle cell from that risk?
Because the cells are abnormally,
Right, they're like actually the sickle, so they come together really easily. And they have some, they're at risk for vaso-occlusive disorder, so sickle cell, AFib, what's the problem with AFib?
because it doesn't fully get out of the atrial
Right, so what's that, what
Clots
happens?
up. clots,
Clots.
throat clots like crazy.
Right, so AFib, if it's a new onset, they don't really cardioverse until they get them anticoagulated, because they can have all these record clots that go out there. Hyperlipidemia, sleep apnea, diabetes.
Yeah. Sounds just like it. Bitch.
All right, so some of the pathophysiology, when you look at this, I'm not gonna ask you, how much cardiac output per minute that you're gonna get to the brain, all that, so there are a few things, this is okay, physiologic. So pathophysiology, I wanted to look more at this one. Systolic pressure above 160 causes overdistension of the cerebral vessels. Our bodies can go up, your fight or flight, so it has a certain amount of stretch, it will go up. That's prolonged over 160. And so prolonged stress, think if you were anxious, taking a test every day, constantly, that's a constant stretch. It will, almost like a varicose vein in like your leg, over time it stretches, so then it gets a little bit bigger, but your cerebral arteries won't do that. So cerebral blood flow increases in response to increased CO2, increased hydrogen ion concentration, but that's regulated by the body, so it's gonna go up and down. Decreased oxygen concentration, if the blood supply to the brain is interrupted for 4 to 5 minutes, we're gonna start having these cellular changes. We'll go back to that. Let me go over here for ischemic stroke. I was showing this a little bit more. So all those slides went into all the cellular level, but what really happens is you have the central cord, you have the stroke, this area here, where it happens. So the central cord is hypoxia due to ischemia. Bless you. Anything more than 4 to 6 hours, 4 to 6 minutes, our body goes into cellular metabolism. So ATP is a big thing, that's depleted. So you go from your aerobic to your anaerobic metabolism that's happening. So that aerobic to anaerobic, you're gonna start producing lactic acid. Lactic acid is not a good thing, right? So, because that's gonna cause more cell death. And as cell death happens, we're gonna have more lactic acid production. So in this area, as cells die, we have that area, so we have our infarct, our injury, and our ischemia. So in this area, that is the infarct, where it's gonna die, we had all this happen with the lactic acid, what's gonna happen? What goes in to take care of a part of the body that dies?
Phagocytes?
Phagocytes, right, the white blood cells, you have all that, moves in, the cytokines and all those. So they try to do what? They do phagocytosis, get rid of all that area in there. That causes a localized ischemic or inflammatory process. So as that goes in, as those cells go in and start to eat away that area that infarcted, it's causing more damage. You have inflammation, so inflammation is swelling, right? So you have swelling in that part of the brain bigger than what's happening more. So that causes more damage to that brain. So that's why it's so you've seen the signs in the commercials, time is brain, that, magic hour or getting to the hospital quickly. The more they get, so we want to stop this anaerobic metabolism and this lactic acid buildup with that. So this area is called ischemic penumbra. That is the surrounding area of cerebral edema and cerebral inflammation, free radicals, and inflammatory mediators released, further peripheral cell death occurs. So this area is dead. What we're trying to save is this area in here, between the dead spot and in here, the penumbra. So when we don't recognize stroke and we don't treat it, we go from having this much dead to that much dead. So those other slides that I thought I deleted, but I didn't. It's not like, that's what this is all saying, must restore blood, 2 to 3 hours, cell dies. That's what this is saying on a short scale. The key is knowing that you have that localized area, you have mediators that come in, cytokines, you have that inflammatory release. That is, so the top line, excessive amounts of amino acids released from necrotic cells. They surround the area of initial damage, only have a few hours. You don't need to know if they're amino acids or anything, just so that you have a localized reaction for your white blood cells.
Do you think it's gonna be necessary to be able to differentiate between primary and secondary?
Primary, secondary, which one?
Like the cell death, there's that primary and then there's after
No.
just knowing.
What you need to know is what I wrote. I put that in. I thought I deleted the other one. Okay, but that's what I was trying to do. Is really know what happens. You have that cell death, you have tissue ischemia. I don't even want to ask you about ATP depletion, but what it is basically you have it, lactic acid builds up and you have that. So not primary, that would be pathophysiology. We're not worried about that, but just know the key to this whole slide, like I said, is that penumbra area, is to stop that area and stop that increased tissue damage. All right, so your ischemic stroke is showing due to a thrombosis or embolism and lodges in the cerebral artery, causing ischemia of the distal tissue. So it's going to be, the distal is further away, so it could be, I don't know, here, so it's going to go down here, the area. So that's what's showing, not exactly, anatomically correct, but in ischemic stroke, you're going to have a damage distal to the area. A hemorrhagic stroke due to a ruptured cerebral artery, like I said, it's going to bleed out and cause abnormal pressure on the surrounding tissues. Brain tissue dies. So it's going to die a lot faster if it's less cerebral. So that's just showing the area that's a little bit bigger there. So this is more of the just beginning with pathophysiology, just going over the beginning. You're not going to test on pathophysiology. We're nurses, so we're going to talk about what we're doing to take care of that. So don't get all flustered over like because what area is dying and how much. The pathophysiology of the large vessels, we look at your thrombotic strokes. It's caused by an inclusion of a large cerebral artery. These are mostly seen in older people. See when they're sleeping and they're resting, why do you think it happens a little bit more when they're sleeping and they're resting? Aside from when they're getting up and walking around. Positioning, that could be some, so it's a thrombus formation. a thrombotic stroke. There-
Is it more,
It's a thrombotic, I should say thrombotic slash embolic stroke.
is it more, something to do with the cholesterol at nighttime?
We produce more, not so much that. Think of what happens when you're walking around, what happens to your vessels? You constrict a little bit more, right? When you're sleeping and relaxing, they dilate a little bit more. So the thrombus slash embolus is the way it's worded, so they can move a little bit more. Positioning too, so what areas, I should say, occlusion, thrombus, for older adults, carotid, you know? Sometimes, you know, they have an 80% and a 90%. Well, if they can't get over their 80%, they only have 10% of blood flow getting through their neck also. So that could be one. I had patients like that with spinal cord injuries because the way they laid and they occluded the one side, so that's possible also. So it's related to narrowing of vessels, a result of the atherosclerosis. And commonly, the central cerebral artery that goes up, and we're going to go over the effects too, but they can have aphasia, neglect. Body neglect is they don't even know their own body. They'll see an arm and they'll say, what is this? Whose arm is that? And it's attached to them. That's when they talk about body neglect. They don't know where it is. Visual field defects also. So this just little picture is just showing a little bit more of a lesion in the right hemisphere. Some of the things you might see, eye deviation towards the lesion, conjugated eye deviation, which is usually both eyes, compared to like head trauma where it's maybe one eye that's deviated. Left-sided hemiplegia, the lesions on the right, remember, the nerves cross over, so if it's right-side lesion. It can be left-sided hemiplegia. Unconsciousness, they could, it's common with how big the artery is, they could have that one. Small vessel, your lacunar, the lacunar, there's different ways people say, but like a lacunar stroke. These are infarcts that affect your small vessels. These are about 10 to like 25% of all your strokes. They're also considered like micro infarcts. Sometimes people will say, or they look on the CT and they see little areas all over, not quite showering, but little micro infarcts all over. Usually after sclerosis, these happen deep in the middle of the brain. So these are by the ventricles, deep in the gray matter. Small portions are usually occluded from the large arteries. Common areas that this can happen is like the brainstem and basal ganglia. So think of, even if you had a small blockage in your brainstem or your basal ganglia, you think of pretty bad effects that can happen with the brainstem. A lot of times these people have a lot of TIAs that happen beforehand. So it's kind of like a warning sign, but if they pick up on it as being a warning sign, a lot of people ignore those. The nice thing with these, about 85% are like mild and people do recover from them. Shows. Let me just show the area on the screen. I'll try to stretch it for next time. So this is more of the cardiogenic embolic stroke. This is just showing when a blood clot from AFib, ventricular thrombi, it could be an MI, CHF, atherosclerotic plaque enters the system. And the one thing that's not out there is trauma could be in there, any type of clot, so an embolic stroke. It's going to go up to the clot, atherosclerotic clot. It could be just from the calcium buildup and the platelets get stuck, so it's not that it's moving anywhere, it's the clot that's happening. And that picture showing the middle cerebral arteries, you can see how big that is and what a big area that it supplies blood to, why it can be so devastating. With atrial fibrillation, showing the EKG of it, so what we had just talked about, the clot, the thrombus formation. So it's always important to look if someone has a history of AFib, and if they're controlled or not, and if they go into it, and how long they've been into it. You know, if it's something that you watch and they're on telemetry and they quick go into AFib, we can convert them out and get out. But if they're in for any for a long time, we wanna make sure that they're anticoagulated. Yes?
They haven't had AFib yet. So do you guys, AFib means that your atrial, the atria of your heart are just fibrillating, like they're just quivering.
Chaos of the atrial, that's what I was always told.
So you think of it, it's just like, it's making a little smoothie of your blood.
Right.
So what happens with all smoothies, there's always a chunk in there.
Right, we were talking about that before you came down.
Oh, I'm sorry.
No, that's okay. So with the, like I said, they usually have the big contractions, and these are just quivering. Not like VFib where it's just really quivering. These are not nice contractions, they're not regular. Some of them are more forceful or not. It doesn't have to be a high rate. Some people, or if they're uncontrolled, they could have rates in the 120s, 110s, 120s. It could be 60 to 80, but the point is, you may have a nice, but then it's slow, it's not a forceful getting all that blood out, like Mike said, and it will sit there and it clots. So the one neat thing they do is the Watchman procedure, that they have that can watch the clots for people that can't be anticoagulated, but they can have lots of different clots that come out.
Is, sorry, is a flutter the same?
No.
AFib and a flutter, no, well, it's fluttering, the atria is, if you look at the textbook, a flutter is regular, your R to R's are gonna be regular, but you have these flutter rates, so your P rate. So the atrial tracing is gonna be irregular, so you can have a 2-to-1 flutter, so you have 2 P's to every 1 QRS, or a 3-to-1, like that way. But when you look at AFib, your R to R's for your QRS, when you measure them out, they're not gonna be regular. You may see 1 or 2 beats,
Oh.
that's why you see 61, 85, 72, because it's irregular. You may have 2 beats, but nothing else. A flutter, they say is gonna be.
You're missing a P wave though, right?
What was that?
You're missing your P wave.
Right, that's the flutter, so they're there.
Yeah.
AFib you can't see. A flutter, they kind of have,
Like that?
AFib you can't see, what do you mean?
the P waves.
Yeah, the P waves you
Right,
can't see,
They're
yeah.
kind of buried all over. Someone get them, and not just, yeah, so this is.
Just think chaos of the atrium.
Right, so this is AFib here, so you can't really see a P that looks like a T wave, but is it a T to C? So flutter would be more like this, those are nice T waves there. But over here, you can't see what it is. They're kind of like that. But the same thing can happen with flutter because it's not as forceful, it's a little bit more organized than fib. So patients with AFib, like 35% of patients with AFib have strokes. 35% of patients with CAD have strokes. Only about 10% of these people have TIAs to begin with. So these strokes are caused by the clots that arise from your platelets, your fibrin, all the clotting factors in it. So I added these pictures in just to show a little bit more with this one. So an embolus is just showing again how it's going to travel. It's going to go to the slower area, a smaller area. And then an embolus, so it doesn't just have to be in the brain, but this is also how a PE, you think of strokes in your brain, but the embolus, how the clot gets in the valve and goes somewhere, and it just shows a smaller branch. So TIA, a key with strokes, is a TIA, transient ischemic attack. People call these mini strokes. It's still considered a stroke. You know, TIA is the precursor to stroke. Some people don't really think they're too concerning. My mother-in-law had one. She said, oh, it's just like a stroke of my eye. It's not just your eye that's affected, although it changed your vision a little bit. They can last from 10 to 15 minutes. They may have these symptoms and then they resolve. 80% are going to resolve within 60 minutes. These symptoms patients usually ignore. Most people, when they have them, have visual disturbances. So that's one thing that would drive in and say, well, I came in because I just can't see out of my right eye. I lose my peripheral vision. So they still drive themselves in, or they ignore it, or they have blurred vision, double vision, and some type of visual disturbances. Blurred vision, double vision, loss of vision is never a normal sign, so that's a key thing to look for with strokes. This is just showing if it's vertebral vertebro-basilar for TIA, and inadequate blood flow to your vertebral arteries. The carotid is more the carotid artery from stenosis. You don't need to know where they are, they arise from by the TIA. So the mini stroke, most of the time they resolve within 24 hours. These patients get admitted and they still have symptoms within 24 hours. It's no longer considered a TIA. So often a warning sign. The manifestations will manifest basically where they are, the small occlusion. Like I said, it's mostly the eye. Sometimes like a finger, they'll come in with one or two fingers if they can't move, or one or two toes, because it's smaller vessels, it's not a large vessel. This slide again says the same thing with stroke. When we get into the symptoms, like next week a little bit more, this is still just the overview. It's gonna depend on what area of the brain it is. So when you study and you look at the brain, not that you have to remember, I'm not gonna say the patient's not speaking, or they have this, what area of the brain is, frontal, or this, or that. The question would be more of the opposite. The patient had a major right-sided stroke. What deficits would you say that they would have? It's more related to where they're at. As with everything, women report symptoms differently than men. Not that their stroke symptoms are anything different, so don't worry about that. It's not like chest pain, like heart attacks. Strokes usually are not painful. If it's hemorrhagic, people complain about the worst pain of their life, but usually it is unpainful, not painful. It's a visual disturbance. It could be a little dizziness, maybe a little weakness in their arm, a headache, a mild headache. Maybe a little slurred speech, and you think it's because they're tired, different things that people ignore. This is just a picture I wanted to show you with a normal brain on this side, and this is an ischemic stroke on this side. So when they get
Fired.
huh? What'd you say? I'm fired?
She's not used to my joking
None of us are.
yet.
So the area of an acute ischemic stroke in this frontal area here. And this one I was just showing, this is more of a transcerebral ultrasound. These are just slides I had that you can see. So it starts out in this area here, and they do the slices. You can see this white area, and it gets bigger. And then they do the Doppler study, so you can see blue. I always remember blue's bad, because it's a little big, it's hypoperfused. So it doesn't look that bad at first in this one, but as they get deeper into the brain, you can see the bigger area that they have. It's just a different color study. So, just as I said, when you think of the frontal, the parietal, and the occipital lobe, the different areas in the temporal lobe. When you read, just go back and look and kind of associate with this, at the frontal lobe. You think of where motor speech and Broca is. What happens in the parietal lobe? You look at the reading comprehension area that's more in the middle, your sensory speech area. So when they have the strokes and they think about the area, how severe things are. So when they have these small microclots deep in, they have more of the speech and reading comprehension problems. So the frontal lobe, I put these on there to make it easier for you. The motor strip, voluntary movement, Broca's area, motor speech, production of speech, written languages. And this is where a lot of patients that have aphasia and apraxia that happens. The prefrontal area, this is really important with strokes, and as you get into head injuries, this is the executive function, intellect, planning, judgment, and personality. These are the patients when they have strokes or injuries to that area, and they can have an inappropriate response. You can tell them, stroke patients, you talk about something serious or sad, they're laughing at you, they're smiling, they're very inappropriate that way. Not that they're trying to be that way. It just happens. So personality changes. It could be somebody, you know, it's always a joke that she was a really nice old woman. Now she's like very mean, very angry, throwing things. It's just the area that's impacted. Executive function. Sometimes these patients no longer can take care of anything. They need power of attorney because they cannot be responsible for financial issues anymore because it hits that area. Temporal lobe, that's auditory, comprehension, interpretation of sound. Once again, emotion and behavior. So you can have patients that you just talk to and they just cry a lot, cry all the time. The behavior changes. Memory, they have some problems with their long-term memory. Interpretation of sound, I don't really hear that they can get confused with sounds, they might not. This is more tied with maybe the aphasia, they can't say things, or the apraxia, they can't put it together. I don't remember ever having patients that sound, they interpret it differently. The parietal lobe, when you have these, also the proprioception, left versus right discrimination, and Tuesday will get in that a little bit more, what those are. Motor planning and the ability to recognize self. Parietal lobe, put a star next to this to remember these, because a lot of your nursing interventions and things you're gonna do for these patients are gonna revolve around the proprioception, the ability to recognize self, right versus left discrimination. So as you read your books in ATI, think about that, okay, if you have someone that has a problem with proprioception or right versus left discrimination, you know, so maybe if I say that someone has, you know, left-sided, their weakness and all is on the left side, they have left-sided discrimination, they don't see that side of their body. You know, they don't see their hand as their own. So a classic question is, the nurse goes to bring the tray into the patient, where's the best place to place the tray? It'll be on the right side. You know,
I'm sorry, is that like a left neglect, like when they forget their whole
Right.
left side or the right, like, it's more like left on the left side.
this would be,
But
yeah, it's
gonna be either
body
way.
neglect.
They don't even realize that they have that other
Right.
side of their body.
Like I said, they could sit there and be like, what's this arm? Whose hand is that? It's yours, but they don't see it. They just don't know it's there, it's attached. So it's exactly what it is. So the ability to recognize self, and that's what the body part's also the discrimination. These are where the questions and everything really revolves around. All the other stuff, it's so involved in the sense that this is gonna be where our nursing actions come from.
Can I just say too, make sure you know the lobes. There's always questions about it'll say, oh, you know, they had a problem to their, because it's not just with stroke, like it could be some other head
Trauma.
injury.
Right.
So just know review what's important with each lobe.
Start learning them now and remembering. So exactly, trauma. That could be a common one, or patient fell and has an injury to the frontal lobe. So those are the ones that you really need to focus on. Occipital lobe, this is the ability to understand the written word and interpret the vision also. So this is where you have a lot of patients that really can't communicate anymore. So manifestations on this paper, or in PowerPoint, they call it a carotid artery stroke. To me, it's carotid artery stenosis. The stenosis causes the stroke. You don't really have a stroke in the carotid artery. It's an occlusion in the carotid artery that's causing a stroke in the brain. So I don't know if this is in your book as carotid artery stroke. I've never heard of it. Was Googling it. Have you heard it called it? Yeah, so I don't know where the term came from. So you have a stenosis in your carotid artery. The stroke is happening up here, so basically, you're not getting any blood flow, you're actually stroking the whole side, what it is. So, that's why it's so important when these patients get their TIAs to have ultrasound done. When you stroke, or when you include your whole carotid artery, contralateral paralysis of the arm, leg, and face you're going to have. If the dominant hemisphere is affected, you're going to have some aphasia. Homonymous hemianopsia. Never say that. I have pictures, we're going to get into that. What that is think of the same side, they lose vision in the eye. So think of your eye, but they're losing the vision on the left side of each eye. It's not the outer, not the peripheral, it's the left side of each eye, so. You have an eyeball? They're losing vision this way. So when they look at you, that same half, it's not like the right and left on one. So they're losing vision on the same, does that make sense? The left side of the eye, so that's a classic thing that comes up. Homonymous hemianopsia. Hard to say, but I have a picture of that. What was that?
Hippopotamus.
I can never say it. All right, so middle cerebral artery, it's such a big artery once again. When you have a patient, this area here is all, let's see, remember that artery coming out is the whole big side. It gets blood to that whole side. Patients present with drowsiness, stupor, coma, they have the contralateral hemiplasia, the arm and face, global aphasia, and that just means everything. They just can't even say words. Everything they can't say. It's not that they have some when they say, "Oh, give me, pencil," or they say the word. They just can't speak anymore. So they have aphasia and apraxia, and they have the homonymous hemianopsia. So contralateral weakness of the foot and leg, that's just another area that's shown right here. Contralateral sensory loss of the toes, foot, and leg. So it's not just weakness, it's also sensory, so they can't move it and they can't feel it. Loss of ability to make decisions or act voluntarily. So they may try to move their arm, they may try to move their leg. Urinary incontinence. Well, it's not a classic sign with anyone can have urinary incontinence. I didn't realize I didn't move that. So that's not like a key sign of this type of stroke. But they're losing that voluntary movement. So other things with a vertebral artery stroke, patients come in, based on where it's at, more pain in the face, nose or eye, this pain. It's usually tingling. The patients usually don't complain of pain. It's more tingling, numbness, and the loss of vision. Problems with gait, they have that very ataxic gait. And dysphagia, they have problems swallowing. This picture is just showing the different eye fields and how they cross over. I think this is, I forget which book this came from. It's from the online thing. It's on one of the online resources that you see. You can Google it too if you wanted to see it or along. So they're just showing the nasal halves, the retinas, the optic nerves, how they crisscross. That's the key thing. Remember, everything crisscross. Diagnosis. The key things that we look at with the stroke when we get in is history of presenting illness, chief complaint, the onset. So the one thing, we don't have this, I'll get to you next week, is FAST. I'm going to just stress this, the FAST exam. F is face, arms, speech, time. So if you think someone's having a stroke, is face. You look at their face and we're looking for what? Droopiness, symmetric. So we're looking at eyes, we're looking at the mouth, right, have them smile. You can have them puff their cheeks, raise their eyebrows, that's another thing too. Some people can't raise their eyebrows. Look for that. Arms, can the person raise both arms and just keep them there? Sometimes they can't get them up, or they have the pronor drift. Sometimes they, have their palms up and do that. But they have a lot of that, sometimes they can't even lift them up. So arms, speech. Is a person's speech slurred? So what type of words would you have a person, so that you have a patient, how would you assess if their speech is slurred? What are some words you would want them? I'll bring a stroke packet and I'll pull up my stuff that I had in the stroke packet.
Words with S.
Words with S. Classic words are like blueberry and baseball. say this word and think of how many movements and your tongue and your cheek and all that you have to say there. You don't want to say hello, what's your name? Sometimes they're one word or one syllable words. You can say them maybe not even opening your mouth all the way. Baseball bat, I forget the one the neurologist like to use. Do you remember that little phrase they have them say?
With no ifs, ands, or buts.
Yeah.
Yes, thank you. No ifs, ands, or buts. Think of how many movements it takes to do that. So you want to sit there for a speech. The key is time. You want to call 911, have them, you know, go to the hospital if you have them. And the hour is the standard, you know, it's under an hour to come into the hospital. So the diagnosis, as with everything, the history and physical, the chief complaint of what's going on. The onset of symptoms, is it acute? The key question, or I should say, anyone know what the most important question is to ask a person, or ask a person's family member or friend or them, when they come in with symptoms? Whether they're in
When
the
did it
hospital-
start?
When was the last time they were seeing normal?
Oh.
Because you might not know when it started. When was the last time they were seeing normal? Because many times, it could be, they come into the emergency room. Well, I saw mom last night at 8 when she was going up to bed, and this morning it's 6 o'clock, her face was droopy. We don't know if that happened at 8:05. We don't know if it happened at 5:30. Same thing in the hospital. You go in and you do an assessment on the patient, you do rounds, you do vital signs, 9 o'clock you go into the bed, and you're like, wow, what's happened? So you know it happened somewhere between 7 and 9, you have a better idea. It all comes down to if they're a candidate for TPA. It's that window of 3 to 4.4 hours. Now, some TPAs can be longer, but classic is going to be 3 to 4.5 hours. So you want to ask them, when was the last time they were seeing normal? Associated symptoms, pain. Put pain like at the back. Don't think of pain as a classic symptom for stroke. Hemorrhagic, yes, but for a classic ischemic stroke, you may have a headache, but it's not the worst headache of their life. It could be nausea, it could be vomiting, it could be weakness. They're coming in with seizures, it's a little bit more. It's usually little things, like I said, it's vision, the visual disturbances that bring people in. It's the weakness, the inability to swallow, to speak, different things. But it's always the people with the visual disturbances that wait and come in later. The other thing, the diagnosis is the NIH stroke scale. And what I wanted to do is just pull it up, so I wasn't going to put it all in here. The NIH stroke scale is the standard, it goes through this is one. So what this is usually a packet. So what it goes through is the level of consciousness. It's something that's used to measure. It goes through level of consciousness. And everything is scored from like a 0 to a 2 or a 0 to 3. So they go through the level of consciousness, and usually it's a physician that does this. They go through and tally the score. This is not a test that you want to do good on. You don't want to go good. The higher the score, the worse the condition is. You want a lower score. So if it's too low, they don't get TPA either. So it's one of those to be in the middle. So one is the level of consciousness, and there are questions that they ask. Alert, not alert, other questions. They're asking them questions about month, age. If they answer 1 right, 2 right, commands, you're asking them to grip and release, best gaze, how they can follow. And basically, they're testing the cranial nerves, balance, and comprehension. Visual, what they're doing is they're looking at if they have hemianopsia, facial palsy, their arms, they're looking at motor, both arms and both legs also. Limb ataxia, sensory, so they're seeing how they feel. Their best language, dysarthria, so this is when they have them say words like baseball, no ifs, ands, or buts. We're going through all these, and extinction and inattention, formerly neglect, they call it. So they go through and they tally these up. This question, or this picture, this is a classic picture that they get. So this comes with, you know, they talk about neglect and comprehension. What do you think that the patient's supposed to pick out in here? Right, things that were flowing.
It's an old picture.
What was that? Right. So these are, I don't know how old
White
this
is
picture is, but
hot.
this is what they keep classic in there, so then to look at the different things
That's funny.
through, go through. This is some of the questions, you know how, down to earth. I got those from work. So these are some things, and hospitals have stroke packets, so they're on the floor, the ED, things for them to say. These pictures, they have them use that look at for apraxia with aphasia also, when they can't pick up. So these are pictures that they have them, you point to and have them say, see if they can get these pictures. And these are some of the other words. I wasn't going for anything else, because I have my other lecture that I had it here. So I was going through the one they had at the school, like those. So there were some. And the other one hasn't, because I matched my other lectures, so it's just like